This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon, and joining me today is our research fellow, Dr. Alara.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the 2026 issue of Acta Otolaryngologica Italica, titled Endoscopic Transnasal Craniectomy, Impact on Staging and Prognosis of Sinonasal Adenocarcinoma.
This is a timely topic, Alara. For those listening who specialize in skull-base work, Sinonasal Adenocarcinoma, or SNAC, presents a unique challenge. Historically, we've leaned on open craniofacial resections, but the shift toward the endoscopic transnasal approach has been transformative over the last decade.
Exactly. And this paper specifically dives into the craniectomy portion of that endoscopic procedure. We're not just talking about a simple tumor debulking or a sinus surgery. We're talking about the formal removal of the cribriform plate, the cristogali, and often the overlying dura to ensure oncological margins.
Right. Now, looking at the core of this study, they're really asking, does the decision to perform an endoscopic transnasal craniectomy, the ETC, actually change how we stage these patients and ultimately how they fare in the long run?
It's an important distinction because, as the authors point out, preoperative imaging, even with high-resolution MRI, can be notorious for underestimating dural invasion or focal extension through the olfactory clefts. The study highlights that the impact on staging is often realized only after the pathologist looks at the bone and dura removed during the ETC.
That's a critical point for our residents listening. When we talk about SNAC, particularly the intestinal type, we know it has a propensity for local invasion. If you aren't taking that cribriform plate, are you really getting an R0 resection? Ilara, what did the study suggest regarding the upstaging of these patients?
The data suggests that a significant percentage of patients are upstaged following the craniectomy. When the surgeons transitioned from a purely endonasal resection to a full transnasal craniectomy, they found microscopic dural involvement in cases where the MRI looked relatively clean. This pathological staging essentially overrides the radiological staging, which then dictates whether the patient needs more aggressive adjuvant radiotherapy.
That's the classic iceberg effect. The tumor you see in the nasal cavity is often just the tip. By removing the bony skull base and the dura, we're essentially performing a margin-controlled resection endoscopically. Now, let's talk about the prognosis aspect. Did the study find that this more aggressive endoscopic approach actually improved survival?
Yes, the paper indicates a correlation between the radicality of the endoscopic craniectomy and local control. By achieving a wider margin at the level of the olfactory bulbs and the frontal dura, the rate of local recurrence, which is the primary mode of failure in SNAC, was significantly reduced compared to historical cohorts where the skull base was left intact.
That's the holy grail of skull-base surgery, balancing radicality with morbidity. In the old days of open craniofacial resection, we had high morbidity, brain retraction, long hospital stays, wound complications. The ETC aims to provide the same oncological radicality, but with the benefits of the endoscopic corridor.
And the study touches on that surgical corridor aspect too. They emphasize that the endoscopic transnasal craniectomy allows for a perpendicular view of the skull base, which is superior for evaluating the lateral margins near the medial orbital wall and the posterior margins at the planum sphenoideal.
I want to dive a bit deeper into the technique mentioned. When we perform an ETC for SNAC, we're often removing the olfactory nerves. This obviously results in anosmia. Did the study discuss how they counsel patients on this, especially when the tumor might only be unilateral?
They did. The authors argue that since SNAC is so frequently associated with the olfactory cleft, preserving the olfactory fibers on the side of the lesion is often oncologically unsafe. In the context of staging and prognosis, the loss of smell is considered a necessary trade-off for a higher probability of a cure. They really emphasize that prognosis improves when we don't shell out the tumor, but instead resect it en bloc with its dural and bony attachments.
It's a paradigm shift. We used to think of endoscopic surgery as debulking, but this paper reinforces that it is a resection in every sense of the word. Let's talk about the reconstruction. If you're doing a full craniectomy, you're creating a significant defect and a high-flow CSF leak.
Correct. The paper notes that the success of the ETC depends entirely on the nasal septal frap. They mention that as the staging of the tumor becomes more advanced, meaning the craniectomy becomes wider, the reconstruction becomes more complex. They advocate for a multi-layered approach, usually an inlay of collagen or fat, followed by the vascularized nasal septal flap.
And that's where the neurosurgeon and the ENT must work in tandem. The hub of this procedure is the skull-base interface. If the staging shows dural invasion, we as neurosurgeons are often the ones performing the dural resection and ensuring the brain is protected.
Exactly. Another interesting point the study made was regarding the prognostic factors. While the craniectomy helps with local control, they found that the histological subtype of the adenocarcinoma, whether it was low-grade or high-grade, still played a massive role in the overall survival, regardless of how wide the craniectomy was.
That makes sense. Surgery can control the local staging, but biology dictates the systemic prognosis. However, by performing an ETC, we give the radiation oncologists a cleaner field to work with. There's less bulky disease, and the margins are better defined.
Dr. Aris, for the residents listening, how would you say this study changes our daily practice? Should we be doing a craniectomy on every snack case?
The paper is quite clear that if the tumor is involving the superior turbinate or the olfactory cleft, the threshold for performing a transnasal craniectomy should be very low. The impact on staging is too great to ignore. If you don't take the bone, you might be leaving microscopic disease that an MRI simply cannot see.
It really highlights the shift toward prophylactic dural resection in certain sinonasal malignancies. If the prognosis is tied to local control and local control is tied to R0 margins, then the ETC is the most logical step in the evolution of the field.
Well said. It's about being as aggressive as the biology of the tumor. Before we wrap up, Alara, were there any specific complications mentioned in this 2026 cohort?
They reported a very low rate of permanent neurological deficits, which is encouraging. The main issues were related to the expected anosmia and occasional crusting in the nasal cavity post-op. Interestingly, the rate of postoperative CSF leaks was under 5%, which speaks to the reliability of the vascularized flaps we use now.
Excellent. It seems the endoscopic transnasal craniectomy is no longer an experimental or advanced addition. It's becoming the standard of care for staging and treating sinonasal adenocarcinoma.
It definitely seems so. A great read for anyone interested in the intersection of ENT and neurosurgery.
Agreed. Well, that's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.
Keep operating with precision. Goodbye.